Okay, so I'll try to run through this because there's a lot to go here. My disclosures, work with a lot of different companies and the NIH to run clinical trials. I'm greatly dependent on my fellows, neurosurgeons, 3 neurosurgeons, 1 radiologist right now, who really help put these talks together and run a really smooth service. They're usually not as happy as they appear to be right now. Carotid disease is a significant cause of stroke. Almost 23% of LVOs are associated with carotid, concomitant carotid disease. 2 ways of treating it: medical management versus revascularization, traditionally endarterectomy, and more recently carotid angioplasty and stenting. So the challenge with carotid angioplasty and stenting, will not cover medical arm or we will not cover endarterectomy, is the aortic arch. That's the challenge. And a lot of the risk from the procedure comes in at the point of navigating these tough arches. So what is a tough arch? A type 3 arch is a tough arch. Bovine arch can be a tough arch, but is not always the case. Acute angulation in the common carotid is the toughest arch because that is the highest likelihood of actually causing injury to the vessel while you're trying to get access. And then you have these aberrant episodes of abnormalities, previous bypasses. Obviously, a shaggy arch, which means a heavy atherosclerotic burden, is a major risk. And then if you have a little bit of everything and you combine it all collectively, that can be a problem as well. So the first thing you need to do when you're looking or thinking about a carotid stent is look at the arch. And you really need to appreciate how much atherosclerotic burden you have, what kind of disease, what kind of arch, what kind of angulations, anatomy. This is clearly a nightmare. Much better to treat this either with an endarterectomy or a direct carotid stent, which is called a TCAR approach, where you just directly access the carotid through a cut down and perform a stent that way. So every time you look at the arch, that's the first step towards carotid, is look at the anatomy and understand the angulation, the narrowing, the atherosclerotic disease. And honestly, from my standpoint, CT angiography is far superior than angiography for this because you can actually see what's happening in the wall of the artery than just the luminal dimensions. For those who may not be familiar, type 1, type 2, and type 3 arches are when the brachiocephalic originates at the apex is a type 1, between the apex and the axilla it's type 2, and when it's below the axilla it's a type 3. So to know when you look at complications during carotid angioplasty and stenting, a good 20%, a good 4 to 6% of them are primarily related to aborting the procedure from the access standpoint. What can you do? If there's no other good choice, this is somebody who should not be endarterectomized, this is not a good TCAR case, well, think medical therapy. Is this asymptomatic disease? If it's symptomatic and really deserves to be treated, and there's no other way, then what we have found is an 8 French Simmons 2 guide can be a very good, solid way of dealing with a complex arch which is otherwise clean. And so you reconstitute it like you would do a Simmons 2 in the subclavian and then drag it into the right place. Another thing that we found is this thing called the Ziggy wire, where you actually go up sequentially with 1 wire at a time with a difficult arch, and once you have 3, with each wire the system doesn't push back, and with 3 wires in place you get a nice railroad to be able to take your guides up there. Bailout options, think of radial, brachial approach, or direct puncture, carotid endarterectomy, or a cut down. I think those are all the options. Radial approach, I personally like to use a 6 French guide in these cases. If the stent would be appropriate, would be a wall stent. You have to keep in mind is that stents which are 8 millimeters or less can get through a 6 French guide. If they are larger, 10 millimeter devices require a 6 French sheath. So you got to keep that in mind. And then you have different kinds of guides that you can use to do the job. So here is a quick case of a radial access. There you can see we have established radial. This is somebody who had severe iliac disease. And once we have in place, we basically reconstitute the Simmons 2 and get access into the common carotid. And over this catheter, we are able to bring the guide, and we then cross the lesion like we normally would with the guide in place. And once we have the stent or the filter is there, then we can go ahead, deploy the wall stent. In this particular case, you can see the wall stent is now going to be deployed. There it comes. And once the stent is fully deployed, then we can go ahead and perform angioplasty if needed. If it's 60% stenosis and it's symptomatic, I will not do angioplasty. And more times than not, I'll do angioplasty before rather than after. So this is an angiogram which is done. Again, symptomatic stenosis, did not go for a perfect result. So this is also something to keep in mind for those who are not neurointerventionalists. You are not going for a perfect angiographic result for neurointervention. You're going for a perfect patient. And it's a little problematic because you say, oh my God, it's still 50%, but you have covered a plaque with a good solid stent, it'll fibrose, and if it re-stenoses, which it almost never does, 3 months later you can do an angioplasty with almost no risk, with no distal protection. So I think that's something to keep in mind is symptomatic patients, don't try to go for a picture-perfect result. Asymptomatic patient, no problem. You can try to go for perfection. Symptomatic patient, the goal is cover the plaque. And then there's brachial access, and we'll sort of skip that. I think access is the most important part of carotid. Now, moving quickly into different kinds of stents. You can have nitinol stents, you can have stainless steel stents, nickel, cobalt alloys are out there as well, which are options. You can have open cell versus closed cell, tapered versus cylindrical, lots of different choices out there. So let me try to see if I can share with you how I think about this. So what are you doing with a stent? There are two things you're doing. One, you're opening the artery, so you need to have enough radial force. Almost all of them have it. But then you're covering the plaque. So if you're covering the plaque in a symptomatic patient, the smaller the tine, the better the coverage. So in a symptomatic patient, you're better off with the smaller tine closed cell design. A big mismatch between internal and common may be a tapered design. You got to sort of keep those things in mind. And there are lots of different choices about, open cell will go around a curve much better. Closed cell will tend more to be a flagpole. So I think you got to keep that in mind. There's some data to suggest closed cell tend to prevent plaque prolapse a little bit better. No randomized data, but that's certainly what I believe, and I certainly do that. So symptomatic lesion, small free cell, closed cell, large mismatch, tapered stent, angulated anatomy, open stent, those are the ways I think about this. Next, moving on to embolic protection. Well, there are two different kinds. There's distal and there's proximal. Distal is all different kinds, balloons, umbrellas of all different kinds. They all work. This is how they typically work. Initially, we used to do balloon occlusion. Now we don't want to really stop the flow, and so we open the filter, and there are lots of different choices between the filter, the proximal, and almost nobody uses the distal occlusion balloon because they don't make it. But I tell you, I think with all the stroke cases we do, this would be useful adjunct to have. The disadvantage of any filter is you need to cross the lesion. And if you measure transcranial Dopplers, that's when a lot of embolic shower occurs, when you take this 3 French device and try to push it up. And no filter perfectly occludes the artery or opposes the wall. So there's always flow around it. So when you look at DWI hits in these cases, with or without filter, you'll always see DWI hits, although they tend to be less with filter than without, as is appropriate. So there are problems with filters. They're not perfect. Here's a quick case of a distal filter. There, again, we have access. These are long cases. I'm showing you the guide is coming up. There is the filter. This is the NAV6. We across the lesion. We get the wire into the petrous, and then we deploy the filter. And almost always, I try to do this more for asymptomatic cases. And there you can see I'm doing plasty before the stenting. I like to do that because I like to get the stent to open up ideally with the device. I don't have to worry about the device elongating, and so I like to do plasty before in cases which are asymptomatic, as is this case, and then deploy the stent nicely across the lesion. And there once we have that in place, then I always do intravascular ultrasound. I'm looking for plaque prolapse. So there's the stent, and I'm looking for a goober that's sticking out. It's rare to see it, but it's rare to cause a stroke with stenting as well. So I tend to see it in 1 or 2% of cases, and that's traditionally what's the rate, and then you go ahead and recapture the filter. There you go, and the case is done. So proximal protection. Proximal protection, the most common one, which is currently available in the market, is a Mo.Ma. It's a single system, but you deliver the distal catheter into the external, and you put a common balloon and you reverse flow. So what you're trying to do is really get the flow coming back from the brain, and this way you have no risk when you're crossing the lesion. I think that is really useful technique here. The problem is it's a 9 French system, so it is a big system, but I think this is my go-to system for symptomatic disease, where I really don't want to cross a shaggy thing, and if the anatomy is conducive, then I like to use a Mo.Ma system. Advantage of proximal, you got the same thing as an endarterectomy. You're basically cross-clamping before you do anything. The disadvantage is there is a little period of ischemia, and those minority of patients that don't have a good circle of Willis. You got to keep that in mind. And a lot depends on proximal access. If you have a lot of atherosclerotic disease in the iliac, it may be a hard thing for you to put a 9 French system through a stenotic vessel. And so I think you got to sort of keep those things in mind. But this is my preferred treatment because the protection to the brain from emboli is more significant with proximal protection. And I won't really show you the case here, and I think I'll sort of stop with this last slide, that guidelines for protection devices, you know, if you have a difficult arch, you have difficult anatomy, and you can't do anything else, I prefer to have a distal filter than no filter. But if the distal anatomy is too tortuous or the patient's symptomatic, I prefer proximal protection. And I'll end there. Thank you.